This is a straight biopsy. We can see in low power, we can appreciate that the epidermis kind of thinning, pushing, maybe infiltrating by this neoplasm, and really hypercellular, hyperchromatic cells. Let's zoom in to see the cytology. Even in this power, we can see this polymorphic hyperchromatic tumor cell. So we know this cell kind of high-grade feature, high-grade looking, and basically this cell kind of pleomorphic with some spindle shape, some epithelial looking cell. So whenever you see this spindle cell proliferation, pleomorphic cell, you have to think of a mnemonic of SLAM differential diagnosis for different kind of high-grade carcinoma, even sarcoma. So the mnemonic SLAM, S, it stands for squamous cell carcinoma, especially this spindle cell looking, that should be high-grade spindle cell squamous cell carcinoma. L, that is leiomyosarcoma. And A, that is AFX. That is what of this slide show, AFX, atypical fibroxanthoma. So when this high-grade tumor just localized in the superficial dermis area, not going into the deep dermis, even subcu, the diagnosis is AFX. If this same lesion going down deep, of course, right now we just have a shape, so we could not rule out when this spindle cell neoplasm just go down, that is pleomorphic dermal sarcoma. So based on the sample we have, we just can make diagnosis of AFX and could not rule out pleomorphic dermal sarcoma. To continue our differential diagnosis, another A we always bear in mind is angiosarcoma. When you see high-grade looking tumor, even this one you do not see really classic slick-like structure, any vascular formation. And then the last one is M, that is melanoma. Then we can do all of our immunostaining to just rule out. Basically, AFX, we do not have specific marker to highlight AFX. If you really would like to highlight some of this lesion, you can use CD10, but CD10 is not specific at all. So when you would like to diagnose this high-grade lesion, you just need to do an immunostaining panel. To rule out squamous cell, you can do P63, P40, CK56, high molecular weight cytokeratin. You can see tons of mitosis here. Then for the leiomyosarcoma, of course, we can do Desmin SMA, but just bear in mind that when you do SMA in AFX, SMA is not really specific but really sensitive. It will show really patchy focal staining even in AFX. So you would like to call SMA positive, you need to see diffuse strong positive. So it will show you leiomyosarcoma. So Desmin could be a better, more specific staining for this rhabdoid differentiation, smooth muscle, skeletal muscle differentiation. Then for angiosarcoma, we know that we can use CD31 and CD31 and ERG. CD34 kind of not that specific or sensitive because in epithelial angiosarcoma, some of them are CD34 negative, And then for melanoma, of course, we all know that we can use S100, SOX10, MART1, MITF to highlight melanoma. But another thing we need to bear in mind that if that is poorly differentiated melanoma, all of these usual melanoma marker would be negative. And some newly described literature mention if you really suspicious for melanoma, you had better to do PRAME. PRAME is more sensitive in poorly differentiated melanoma. So you can have a try to use PRAME to highlight when you're highly suspicious for melanoma. You even can see these high-grade multinuclear cells inside this lesion. So this is AFX. Just rule out other spindle cell carcinoma or sarcoma. Another example of AFX. This one, usually AFX, you will have all the epidermis just gone because this ulcerated surface. And then you can see these pleomorphic spindle looking cells. Sometimes you can see this cytoplasm kind of clear, bubbly, so that is the name to call it kind of lymphoma. So the name is atypical fibroxanthoma. So basically still haphazard growth of these spindle cells. You do not see any granular structure, just these high-grade looking pleomorphic hyperchromatic cells. Just remember to do the immunostaining to rule out other malignancy. Then you can call AFX. Let's see a few more examples. This one is more of like foamy cytoplasm, more like of xanthoma cytoplasm. But when you look inside, still this spindle cell shape cell hyperchromatic, really pleomorphic, hyperchromasia, high grade looking. So this example I just like to show you this foamy cytoplasm. But whatever this morphology can show you, you still need to do the staining to just make your final diagnosis. Again, this is one more sample of atypical fibroxanthoma. In this big excisional sample. And this lesion kind of almost go down to subcutaneous fat here. And then this one is a little bit different because when you go to high power, this kind of like hypocellular, but the cell is really atypical. Pleomorphic, hyperchromasia. So still fall into this atypical fibroxanthoma entity. This slide just would like to show you this lesion sometimes can show this hypocellular morphology, but when you look down, you still see this hyperchromatic atypical high-grade carcinoma